Today, we are going to discuss acromegaly, an endocrine disorder caused by chronic excess secretion of growth hormone in adults. The clinical manifestations of acromegaly are mainly mediated by IGF-1, which is produced primarily by the liver in response to GH stimulation. IGF-1 promotes the growth of bones, soft tissues, and internal organs, leading to the characteristic features of this disease. Definition: acromegaly is a disorder caused by chronic excess growth hormone secretion after epiphyseal plate closure. Because the growth plates have already fused, patients cannot grow taller. Instead, they develop progressive enlargement of the hands, feet, facial bones, soft tissues, and internal organs. It is important to distinguish acromegaly from gigantism. Gigantism occurs when GH excess develops before epiphyseal closure, resulting in excessive linear growth and very tall stature. Acromegaly occurs after epiphyseal closure, so the patient develops tissue overgrowth without an increase in height. Epidemiology: acromegaly is a rare disorder. Although the disease often begins years earlier, its progression is slow, and symptoms develop gradually over many years. As a result, most patients are diagnosed between 40 and 60 years of age, when the characteristic physical changes become more apparent. Causes: approximately 95% of cases are caused by a GH-secreting pituitary adenoma, specifically a somatotroph adenoma of the anterior pituitary. Normally, GH secretion is regulated by hypothalamic hormones, but in a pituitary adenoma, the tumor secretes GH autonomously, resulting in persistently elevated GH and IGF-1 levels. A much less common cause is ectopic secretion of growth hormone-releasing hormone, GHRH, or, rarely, ectopic GH secretion by non-pituitary tumors. Examples include pancreatic neuroendocrine tumors, bronchial carcinoid tumors, rarely, small cell lung carcinoma. In cases of ectopic GHRH secretion, the pituitary gland is secondarily stimulated to produce excessive GH. Clinical features: the clinical manifestations of acromegaly can be divided into two groups. Features caused by excess GH and IGF-1, which produce tissue overgrowth. Features caused by the mass effect of the pituitary adenoma, particularly when it enlarges beyond the sella turcica. Neurological features: mass effect of the pituitary tumor. These symptoms are caused by the enlarging pituitary adenoma rather than by GH excess itself. Headache. Headache is a common presenting symptom. It results from stretching of the dura surrounding the sella turcica by the expanding pituitary tumor. Visual field defects. As the adenoma enlarges superiorly, it compresses the optic chiasm. This classically produces bitemporal hemianopia, meaning loss of the temporal, peripheral, visual fields in both eyes. Patients often complain that they cannot see objects approaching from either side. Diplopia. If the tumor extends laterally into the cavernous sinus, it may compress cranial nerves 3, 4, or 6. This results in double vision diplopia, ophthalmoplegia, restricted eye movements. Facial features. The face gradually becomes larger and coarser because GH and IGF-1 stimulate both bone growth and soft tissue hypertrophy. Coarse facial features. Patients develop thickened skin, enlarged nose, thick lips, prominent supraorbital ridges. These changes occur slowly over many years, so patients often do not notice them until old photographs are compared with their current appearance. Prognathism. One of the characteristic skeletal changes is prognathism, which refers to enlargement and forward protrusion of the mandible. This may cause malocclusion, increased spacing between the teeth, difficulty chewing, macroglossia. The tongue becomes enlarged due to soft tissue hypertrophy. Patients may complain of difficulty speaking, difficulty chewing, snoring. Macroglossia also contributes to obstructive sleep apnea, but it is not the only mechanism. Sleep apnea in acromegaly is multifactorial and results from macroglossia, thickening of the pharyngeal soft tissues, enlargement of upper airway structures, narrowing of the upper airway. Hands and feet. One of the earliest clues to acromegaly is enlargement of the hands and feet. Patients often report that their rings no longer fit, Their gloves become tight. Their shoe size gradually increases. The hands become broad and thick, producing the classic spade-like appearance. These changes result from enlargement of both bone and surrounding soft tissues. Excessive sweating. Patients frequently complain of profuse sweating, hyperhidrosis. This occurs because GH stimulates hypertrophy and increased activity of the sweat glands. The skin may also become thick, oily, moist. Excessive sweating is one of the most common symptoms and often improves after successful treatment. Other important clinical features. Musculoskeletal manifestations. Patients commonly develop joint pain, arthropathy, back pain, carpal tunnel syndrome due to median nerve compression. Cardiovascular manifestations. Chronic GH excess may lead to hypertension, left ventricular hypertrophy, acromegalic cardiomyopathy, heart failure in advanced disease. Cardiovascular disease is one of the leading causes of death in untreated acromegaly. Metabolic manifestations. GH antagonizes insulin action, leading to insulin resistance, impaired glucose tolerance, diabetes mellitus, visceral enlargement. Internal organs may enlarge, including heart, liver, kidneys, thyroid gland. This generalized enlargement is known as visceromegaly. Gastrointestinal manifestations. Patients have an increased prevalence of colonic polyps, which is why many guidelines recommend periodic colonoscopic screening after diagnosis. Now that we have discussed the causes and clinical manifestations of acromegaly, let us move on to its complications and the investigations used to establish the diagnosis. The complications of acromegaly arise primarily from prolonged exposure to excess GH and IGF-1. These hormones promote progressive enlargement of soft tissues, bones, and internal organs, affecting multiple body systems. Early diagnosis and treatment are essential because many complications are reversible if GH excess is controlled before permanent structural damage occurs. Complications. 1. Hypertension. Hypertension develops in approximately 30 to 50% of patients, making it one of the most common cardiovascular complications of acromegaly. Several mechanisms contribute to elevated blood pressure, including increased sodium and water retention, increased peripheral vascular resistance, endothelial dysfunction, left ventricular hypertrophy. Hypertension significantly increases the risk of cardiovascular morbidity and mortality if left untreated. 2. Insulin resistance and diabetes mellitus. Growth hormone is a counter-regulatory hormone, meaning it opposes the actions of insulin. Excess GH causes reduced glucose uptake by skeletal muscle and adipose tissue, increased hepatic glucose production, increased lipolysis, leading to elevated free fatty acids that further impair insulin action. Initially, patients develop insulin resistance. Over time, pancreatic beta cells fail to compensate, resulting in impaired glucose tolerance. Type 2 diabetes mellitus. 3. Obstructive sleep apnea. Obstructive sleep apnea is a frequent complication of acromegaly. It develops because GH and IGF-1 cause enlargement of the upper airway structures, including macroglossia, enlarged tongue, thickening of the pharyngeal soft tissues, enlargement of the laryngeal structures, narrowing of the upper airway. Patients commonly complain of loud snoring, excessive daytime sleepiness, morning headaches, poor concentration. Successful treatment of acromegaly often improves sleep apnea, although some patients continue to require specific therapies such as continuous positive airway pressure (CPAP). 4. Cardiovascular disease. Cardiovascular disease is the leading cause of death in patients with untreated acromegaly. Long-standing GH and IGF-1 excess may produce left ventricular hypertrophy, acromegalic cardiomyopathy, diastolic dysfunction, cardiac arrhythmias, heart failure. Patients are also at increased risk of ischemic heart disease, particularly when hypertension and diabetes are present. Early treatment can improve cardiac function before irreversible myocardial damage develops. 5. Osteoarthritis and arthralgia. Excess GH stimulates growth of cartilage and bone. Initially, joint cartilage becomes thickened. However, chronic mechanical stress eventually leads to degeneration of cartilage, resulting in osteoarthritis, chronic joint pain, arthralgia, joint stiffness, reduced mobility. Unlike soft tissue enlargement, established osteoarthritis often persists despite successful treatment of acromegaly. 6. Carpal tunnel syndrome. Soft tissue overgrowth around the wrist compresses the median nerve within the carpal tunnel. Patients typically present with numbness, tingling, pain involving the thumb, index finger, middle finger, and radial half of the ring finger. Weakness of thumb movements in advanced cases. On physical examination, both Tinel's sign and Phelan's test may be positive. 7. Colonic polyps. Patients with acromegaly have an increased prevalence of colonic adenoma, hyperplastic polyps. There is also an increased risk of colorectal carcinoma, although the exact magnitude of this risk remains debated. For this reason, many endocrine societies recommend screening colonoscopy at the time of diagnosis, with subsequent surveillance based on colonoscopic findings and control of GH and IGF-1 levels. 8. Multiple endocrine neoplasia type 1, MEN 1. A small proportion of GH-secreting pituitary adenoma occur as part of multiple endocrine neoplasia type 1, MEN 1. MEN 1 is an inherited syndrome characterized by tumors involving the parathyroid glands, pituitary gland, pancreatic neuroendocrine cells. The most common endocrine abnormality is primary hyperparathyroidism, resulting in hypercalcemia, elevated parathyroid hormone, PTH. Therefore, acromegaly presenting in a young patient or in association with hypercalcemia or a family history of endocrine tumors should prompt evaluation for MEN1. Investigations. The diagnosis of acromegaly requires biochemical confirmation, followed by radiological localization of the underlying lesion. 1. Serum IGF-1 level. The first-line screening test for suspected acromegaly is measurement of serum IGF-1. Growth hormone is secreted in a pulsatile manner throughout the day, making random GH measurements unreliable. In contrast, IGF-1 has a much longer half-life and remains relatively stable throughout the day, making it the preferred screening test. An elevated age-adjusted IGF-1 level strongly suggests acromegaly, whereas a normal age-adjusted IGF-1 level essentially excludes active acromegaly in the absence of conditions that interfere with IGF-1 measurement. 2. Oral glucose tolerance test, OGTT, with GH measurement. If IGF-1 is elevated, the diagnosis is confirmed using an oral glucose tolerance test with serial GH measurements, which remains the gold standard biochemical confirmatory test. Principle. Under normal physiological conditions, ingestion of 75 grams of oral glucose suppresses GH secretion through hypothalamic and pituitary feedback mechanisms. GH is measured before glucose administration and at intervals during the following 2 hours. Normal response. In healthy individuals, GH suppresses to very low levels. Traditionally, GH suppresses to below 1 microgram per liter, while many modern ultrasensitive assays use a lower cutoff of below 0.4 μg per liter. Acromegaly. In patients with acromegaly, autonomous GH secretion prevents normal suppression. Therefore, the diagnosis is confirmed by failure of GH suppression below the assay-specific cutoff, despite oral glucose administration. 3. Pituitary MRI. After biochemical confirmation, contrast-enhanced MRI of the pituitary gland is performed to identify the underlying lesion. MRI provides information about presence of a pituitary adenoma, tumor size, invasion of surrounding structures, compression of the optic chiasm, extension into the cavernous sinus. Approximately 95 to 98% of acromegaly cases are caused by pituitary adenoma, and MRI detects the majority of clinically significant tumors. 4. Further radiological imaging. If biochemical testing confirms acromegaly but pituitary MRI is normal, an ectopic source of GH or GHRH secretion should be considered. Further imaging may include CT scan of the chest, CT or MRI of the abdomen. Functional imaging when indicated. These studies aim to identify tumors such as bronchial carcinoid tumors, pancreatic neuroendocrine tumors. 5. Additional laboratory investigations. Additional laboratory studies help assess associated disorders and complications. Serum calcium. Hypercalcemia is not a direct manifestation of acromegaly. When present, it should raise suspicion for primary hyperparathyroidism, particularly in patients with MEN1 syndrome. Serum phosphate. Growth hormone increases renal phosphate reabsorption, so patients may develop mild hyperphosphatemia. Although not diagnostic, this finding supports the biochemical effects of GH excess. Serum prolactin. Serum prolactin should also be measured because some pituitary adenoma co-secrete both GH and prolactin. Large pituitary tumors may elevate prolactin through the stalk effect, in which compression of the pituitary stalk reduces dopamine delivery from the hypothalamus, thereby removing inhibition of prolactin secretion. Now that we have confirmed the diagnosis of acromegaly, the next step is management. Treatment includes surgery, medical therapy, and radiotherapy. Surgery. Transsphenoidal adenomectomy. The first-line treatment for most patients with acromegaly is transsphenoidal adenomectomy. The pituitary adenoma is removed through the nasal cavity and sphenoid sinus, avoiding the need for an open craniotomy. Surgery aims to remove the GH-secreting adenoma, normalize GH and IGF-1 secretion, relieve compression of surrounding structures, such as the optic chiasm, preserve normal pituitary function whenever possible. The success of surgery depends mainly on the size of the adenoma. Microadenomas have a cure rate of more than 85%. Macroadenomas have a lower cure rate of approximately 40 to 50%, because they are more likely to invade surrounding structures and cannot always be completely removed. Medical therapy. Medical treatment is used when surgery is not possible, surgery is unsuccessful, residual disease remains after surgery. There are three major classes of medications. Somatostatin analogs. The main drugs are octreotide, lanreotide. These drugs mimic the action of somatostatin, the natural inhibitor of GH secretion. They suppress GH release from the pituitary adenoma, leading to a reduction in IGF-1 levels and improvement of clinical symptoms. According to the textbook, they are administered by intramuscular injection every 14 days. Common adverse effects include gallstone formation, sinus bradycardia, dopamine agonists. The main drugs are bromocriptine, cabergoline. These medications are particularly useful in patients whose pituitary adenoma also secrete prolactin. Among them, cabergoline is more effective and is generally preferred because it produces better biochemical control. Growth hormone receptor antagonist. The only available drug in this class is pegvisomant. Unlike the previous medications, pegvisomant does not inhibit GH secretion. Instead, it blocks GH receptors in peripheral tissues, preventing GH from stimulating the production of IGF-1. As a result, IGF-1 levels normalize in many patients, leading to improvement of symptoms. Because pegvisomant acts at the receptor level, GH levels remain elevated, and the pituitary adenoma is not reduced in size. Therefore, patients require periodic pituitary MRI during treatment. Liver function should also be monitored because the drug may cause liver enzyme abnormalities. Radiotherapy. Radiotherapy is considered when surgery and medical therapy fail to adequately control the disease. Stereotactic radiotherapy is preferred because it delivers focused radiation to the pituitary adenoma while minimizing damage to surrounding tissues. The major long-term complication is hypopituitarism, so patients require annual assessment of pituitary hormone function. Prognosis. If acromegaly is left untreated, patients have an increased risk of cardiovascular complications. The textbook states that left ventricular failure is the most common cause of death in untreated patients. Successful treatment that normalizes GH and IGF-1 levels significantly improves prognosis and reduces long-term mortality.